Good morning, good afternoon, and good evening. Welcome to Webinar World Tour. And I'm extremely happy to announce today's speaker, who is Dr. Stephen Chen, who is from Australia, Melbourne. I'm Mukta Sandhu, Senior Scientific Education Manager from Geislich Pharma, Switzerland. I am extremely sure that Dr. Stephen Chen, who is going to talk us about the immediate implant placement case selection, it's going to be a webinar to really remember. Let me give you a little bit of information and introduction about Dr. Stephen Chen. Dr. Stephen Chen is a specialist periodontist in private practice in Melbourne, Australia, and he's clinical associate professor at the Melbourne Dental School. Dr. Chen is a past president of ITI and has served as a chairman of ITI Education Committee. In Australia, he has served as a chairman of the Australian and New Zealand Academy of Periodontists, also AOS, and also Australian Society of Periodontology. He has been awarded honorary life membership of ITI and AOS for his long-standing services to these two organizations. Dr. Chen's clinical and scientific interests are in the field of periodontal tissue regeneration, bone grafting, and post-extraction dental implant outcomes. So thank you very much, Dr. Chen, and I am really looking forward to listen to you. Over to you now.
Mukta, thank you so much for the kind introduction. It's a great pleasure to be involved with this Geislich World webinar series. And I'm very pleased to be able to present to you on this topic of immediate implant placement and case selection. As we all know, the topic of immediate implant placement is a topic that has had enduring interest now for at least the last 30 years. And it seems very attractive for us to be able to take out a tooth and place an implant immediately into an extraction socket. The gap is already there. And if the tooth is in the right position, it seems so intuitive to place the implant into the extraction socket. But of course, over the years, we realized that whilst this is a very attractive procedure and it can work in many cases, there are risks associated with this, which we need to understand. And the whole objective of treating our patients is to ensure that we provide them with outcomes that are long-lasting, durable, with minimal risk of long-term complications. What I'd like to do in the presentation today is to focus really on single tooth replacement in the maxillary anterior region, because not only are there functional requirements for implants here, but there's also aesthetics and getting good soft and hard tissue aesthetics in replacing teeth in the aesthetic zone. So I would like to focus the presentation predominantly on a single tooth implant replacement in the anterior maxilla, where we have a lot of data, in fact, on immediate implant placement and how to select the correct cases. What I would like to cover in my presentation today are a few things. I will start off with speaking about some definitions. I will outline what are the therapeutic objectives that we have when we treat patients with implants, especially in the aesthetic zone. In other words, what do we want to achieve with bone and bone regeneration, and what do we want to achieve with soft tissue and soft tissue aesthetics. And then I'll talk about understanding the risks, and this will be the bulk of the presentation, because it's only by understanding the risks can we really make an objective assessment of our patients to select the correct cases. And I'll go through this with you in some detail. And then we'll speak about the selection criteria and then finish up with some case reports. All right, let's begin with definitions. And I'd like to bring to you this recent definition of implant placement and loading. And this was proposed by the ITI at the 6th ITI Consensus Conference in 2018. And for the first time, it brought together the classification for the timing of implant placement after a tooth is extracted, as well as the time to load the implant after the implant has been placed. And for a long time, the research and the interest has kind of separated these two. But we came to a realization that when you see a patient and you decide that an implant is an appropriate replacement solution for them, not only do you plan the timing of the placement, but you should also be planning the loading protocol for that case right from the beginning. And therefore, it made so much sense to bring these two classifications together. So you'll see here on the left-hand side of the screen, you'll see the ITI's classification for the placement time after tooth extraction. Type 1 refers to an immediate implant, an implant placed after the tooth has been taken out and is part of the same surgical procedure. Type 2 is early implant placement with soft tissue healing. And this is typically between 6 to 8 weeks after a tooth has been taken out, depending upon the size of the socket and how much time it will take for the soft tissues to substantially heal and close over the socket. The timing is not as important as the biological outcomes that we desire. So type 2 really focuses on soft tissue healing. And that, as I said, is typically 6 to 8 weeks in duration. Then there is type 3 placement, which is also in the early phase of healing and was also therefore referred to as early placement. But this time we wait a little bit longer to get substantial bone healing into the extraction socket. And once again, this depends upon the size of the tooth socket and the complexity of the tooth socket and the number of roots. So for example, a lower incisor site will have bone healing much more rapidly than, say, a maxillary molar site. So the timing of the placement then depends upon the situation with the site. But typically it's 10 to 12 weeks after a tooth has been extracted. And then finally, we have late placement, and this is where an implant is placed into a substantially healed site. Then on the right side, we have the loading time after placement. Again, this is defined by the ITI, and we've given this letters A, B, and C. So A refers to immediate loading, where the implant is placed and a prosthesis is connected to the implant within the first week of the implant being placed. So usually for single teeth, it's done on the same day. Sometimes for full arch situations, they might wait a few days because there are some laboratory procedures that have to be done. And so the definition allows the little bit of leeway in terms of time. So you have 1 week. If the implant is loaded, it's referred to as immediate loading. Early loading, B, is implant loading between 1 week and 2 months after the implant has been placed. And then C, which is conventional loading, is if the implant is loaded greater than 2 months after the implant has been placed. So how do we combine these two classifications? Well, let's look at immediate implants. So we have type 1, which is an immediate implant, and we can then combine it with either immediate, early, or conventional loading. Now, most clinicians will not load an immediate implant in the early healing phase because there are some risks because the implant does lose a little bit of its stability in the early healing phase. So generally speaking, with immediate implant placement, early loading is not performed, but we do perform immediate loading and conventional loading. So we could have a type 1A, which is immediate implant placement and immediate loading, or in the case of a single tooth, connection of an immediate provisional crown, and that's usually taken out of functional occlusion. Or we could have a type 1C, an immediate implant is placed, but it's not loaded. It's allowed to integrate without a prosthesis, and then it is loaded sometime later once the integration of the implant has been confirmed. So these are a couple of examples. So type 1A, immediate placement and immediate provisional crown. You see an implant has been placed, the socket has been grafted, and then a provisional crown has been connected on the day of the procedure. So the implant then is allowed to integrate with a prosthesis in place, although it's not in functional occlusion, but nevertheless, the implant does receive a certain amount of loading from the soft tissues, the lip, and the pressure of the tongue. So it's not a completely unloaded situation, but that it's allowed to then integrate. And once the implant has been confirmed to have osseointegrated, then a new impression is taken and the delivery of the final crown is made. Okay, so that's type 1A. Then in contrast, type 1C, you place the implant, and the implant then is allowed to integrate unloaded. So no prosthesis is connected. Once the implant has been confirmed to have osseointegrated, then the prosthodontic procedures continue, and then the implant is loaded. So that's type 1C, where the loading of the implant takes place after 2 months from the time the implant is placed. Okay, so let's now move on to the next part, which is to talk briefly about the therapeutic objectives of our treatment. And this is quite independent of the timing of your implant placement. So whether you choose to place the implant as an immediate implant, or you choose to place the implant early in the healing phase, or if it's a late implant placement, particularly for single tooth implant replacements, we are looking at the same therapeutic objectives, and we need to consider 2 tissue components. We need to consider the hard tissues and the soft tissues. And this is particularly relevant on the facial aspect of the implant. And this is a CBCT of the same implant case. You see that upper right, or that maxillary right central incisor. So our therapeutic objectives is to ensure that the facial aspect, of course, the implant must be completely in bone, but the facial aspect has to have a thick layer of bone, preferably 1 to 2 millimeters in orofacial thickness. And we also want to have thick soft tissues, at least 2 millimeters of peri-implant soft tissue in that marginal tissue region. And if we can achieve this, whether it's with an immediate implant or early implant placement, then we have a good opportunity to get optimum aesthetic results, because we have nice tissue form, ridge contour, and the light striking the teeth in the soft tissues reflects off like it does on a natural tooth with a natural root eminence. So those are our therapeutic objectives. And why do we need the thick bone? Well, we know from early CBCT studies done almost or over 10 years ago now, that when they looked at CBCT of the facial bone, where you did not see facial bone, and you can see the CBCT on the left, the facial bone cannot be seen, but you do see the soft tissue. And on the image on the right, you can see both the thick bone and the thick soft tissues. And in cases that did not have visible bone on the CBCT, those cases were associated with a higher incidence of soft tissue recession, and especially if the soft tissues were thin. But please be aware, of course, that with CBCT, just because you don't see the facial bone on a scan, it doesn't mean it's not there. It could be very thin. So there is a certain amount of issues with resolution and detection of thin layers of bone on the front of implants. But nevertheless, if it's thin or non-existent, there is a higher propensity for recession to occur. And therefore, what we need to do is we need to reconstruct the tissues, reconstruct the facial bone so that we have a thick facial bone. And I'll speak to you about this later, but we cannot rely on the native bone to ensure that hard tissue thickness. So whether it's with immediate implants or early implant placement or late placement, we try and build back, if possible, a layer of thick bone to ensure that we have, as I'll show you with the pointer here, this thick layer of bone at that marginal region. Then, as I mentioned, we need thick soft tissues, because we know that the soft tissue frames the crown. It frames the prosthesis, and it gives the natural appearance of the tooth and the eminence of the roots, if it's convex in its appearance and if it's healthy. And soft tissues are critical for optimal aesthetic outcomes. So you can see here a CBCT scan of this same case, which has thick soft tissues. You'll see that the bone on the facial is not particularly thin. It's not even 1 millimeter thick, but the soft tissues are 3 millimeters in thickness. So if you can achieve that combination of bone and soft tissue, thick bone, thick soft tissue, or if the bone is not so thick, then at least you have thick soft tissue, then you have a good chance of achieving a good aesthetic outcome with your implants. And this is where, with immediate implant placement, often we have to add soft tissue, because if we are dealing with the inherent tissue thickness on the facial, very often it's thin to medium thick. And to ensure thick tissue, we have to add thick tissue, either with autologous soft tissue grafts or with soft tissue substitutes, to ensure we achieve this soft tissue thickness. With early implant placement, on the other hand, we can wait, although you can see here the site has resorbed and is flattened off. But when the flap is raised, and you can see how thick the soft tissues are, there's a natural thickening of the soft tissues that if the flap is manipulated correctly, and we can displace that to the facial of our implant, then we can achieve good soft tissue thickness without the need for additional soft tissue grafting. So two different ways of achieving soft tissue thickness, but the objective is the same. We still want thick, soft tissues. And finally, under the treatment objectives, we would like to reconstruct the facial bone coronal to the implant abutment junction. And what do I mean by this? We have a look at this CBCT. This CBCT in the sagittal view, the black dotted line illustrates the junction between the implant and the prosthesis and the abutment. We can see the facial bone, the crest is coronal to the implant abutment interface. So today, this is what we aim to do. We aim to build that facial bone up so it's coronal to that interface, because then you have the soft tissue crest. And there is a biologic width of about 3 millimeters that's established between the tip of the papilla and the crest of the bone. And if we can achieve this, then we will be able to have soft tissue stability over time, because the soft tissue is, in terms of its vertical positioning, is supported by the crestal bone. And we need to do this with our regenerative procedures. And so this case, you can see there is a dehiscence on the facial aspect. A healing abutment is connected. The dehiscence is grafted in this case with just locally derived autogenous bone. This is an early implant placement protocol according to Danny Booza's protocol. And then we overbuild the facial aspect, in this case with particulate DBBM or Geisslich bioos. And you can see that this graft is taken right over the healing abutment, almost to the top of the healing abutment, because not only are we wanting to build thickness, but we're also wanting to build crestal bone height. And the net result is the radiograph you see on the left, the CBCT. You can effectively reconstruct the bone crest to be coronal to the implant abutment junction. Okay, so those are our therapeutic objectives with hard and soft tissue, and we must bear this in mind when we think about immediate implants. Let's move on to understanding the risks as a basis for proper case selection for immediate implant placement. I like to describe this as risk-aware case selection. It's like driving on the freeway, defensive driving, anticipating what might occur with the driver in front of you, or the driver behind you, or the driver behind you in your rearview mirror. We are anticipating all the time what others are doing, and we then try and take steps to avoid, in the case of a motor vehicle, an accident, but in the case of implants, complications with the implants. So this is, I think, an important thing to understand. So firstly, what we have to do is we have to identify what the complication is. So once we can identify what the complication is, we can then look to see what the risk factors are that contribute to that complication. And by understanding what the risk factors are, patient risk factors, site risk factors, the clinician or operator risk factors, we can therefore select the cases that will minimize those risks and therefore minimize the complications. So understanding the risk for complications allows for a proper case selection that increases the long-term predictability and minimizes adverse outcomes. And so too with immediate implants. We need to understand what the complications are. So let's look at complications with immediate implants. And of course, there are a number of complications that we can talk about. Implants too close to a tooth, implants that accidentally impinge upon the neighboring tooth, implants that are too close together, and so on. Right? But what I'd like to talk about are the two main complications we see with single tooth immediate implants. The first is recession of the midfacial mucosa. The second, which is not spoken about quite as often, but I see as a significant risk factor for immediate implants is peri-implant infection, peri-implantitis. This might happen 5 years after an immediate implant is placed. And you can see here, this was an immediate implant, immediate loading case referred to me, and there is infection and suppuration around the implant. So let's look at these two complications and spend a little bit of time with them. I'd like, first of all, to speak about recession of the midfacial mucosa. And I wrote a systematic review in 2014 for the 5th ITI consensus conference. That was in 2013. And we looked at studies of immediate implants that also documented the frequency of recession, not just the average recession, but how many cases had recession, how many cases did not have recession. Recession or no recession, good aesthetics or adverse aesthetic outcomes. And what we found was that in studies that had been done without strict inclusion and exclusion criteria. And what do I mean by this? Inclusion criteria like thick, soft tissues or an intact facial bone or lack of recession prior to treatment. So there are well-defined inclusion and exclusion criteria. Now, studies that did not have these a list of inclusion and exclusion criteria and treated all cases that sequentially that required an extraction and implant, then the studies reported a frequency of recession of greater than 1 millimeter at the mid-facial mucosa of between 9 to 41%. 9 to 41%. Now, even if you take the lower end, let's say 10%, I think today most of us, if we are practicing implant dentistry and doing immediate implants, will not be able to tolerate a 10% aesthetic complication rate. So something definitely relates to the inclusion and exclusion criteria, right? So that's why the presentation today focuses on this and case selection. Now, when we look at recession of the mucosa, we can see this happens in two very distinct time frames. The first time frame is very early in the post-implant placement period, or very soon after the prosthesis or the crown is connected to the implant. We see recession happening very fast. The second is recession that might occur several years later. So everything is perfect. Aesthetics, soft tissues are great. And then we see the recession 3, 4, 5, 6, 7 years down the track as it starts to happen. So these are the two time frames. Now, with early recession, this is almost always due to facial malposition of the implant. The implant has been placed too far forward in the extraction socket. And in particularly, if you're dealing with a patient who has a thin, soft tissue phenotype to begin with, then that recession can be quite severe. The second recession, which is late in the post-placement period, is almost always due to modeling of the bone. The facial bone is undergoing changes and is not stable, and gradually it recedes, and eventually the soft tissue follows the bone as the crestal marginal bone recedes. So let's look at the first part, which is facial malposition. So this is an old case that I treated more than 20 years ago. The upper left central incisor has been extracted and a flapless immediate implant has been placed, and you can see the heel site after 3 months. But already, just on these images, you can see there's already some soft tissue recession compared to the right central incisor. And now this is 1 year after the crown has been placed. There's recession. This implant has been placed into a very slight facial malposition. It's not severe, but it's very slight. And it's enough to thin the soft tissue and create an unstable bone soft tissue relationship. And look what happens after a period of another 3 years. The soft tissue recession continues over a period of time. So of course, this is something we want to avoid with implants, and why it's so important and critical for the implants to be placed in the correct position. So facial malposition is something that we need to avoid at all costs with immediate implants. And it's actually a technical error. It's an error by the operator or by the clinician placing the implant into that facial malposition. The implant and the abutment crown complex in a facially positioned implant creates or extends this in the transition zone, or what's called the subcritical zone. It extends that complex towards the natural contour of the alveolar ridge and the soft tissues. And we know we cannot extend beyond the natural confines of anatomy. So let me try and explain this in a different way. Let's look at this occlusal view. And you'll see that the right central incisor is an implant restoration. But we can see the contour of the ridge. So this is very nice and very harmonious. The implant's in the correct position, and we have nice, thick, soft tissue and thick bone. But if the implant was pushed too far to the facial, then the result of going too far to the facial is that the soft tissues are stretched and become thin. The bone recedes on the facial of the implant, and ultimately this results in soft tissue recession. So another way of looking at this schematically, so the implant in this diagram is the upper right central incisor, and you'll see the frontal view, and then you see also the sagittal view, and towards the left-hand side is the facial side. So the red line that I've drawn here reflects the symmetrical position of the two central incisors. So this is the ideal position of the soft tissues. Now, all we need to do, and remember, we cannot extend the soft tissues beyond its natural confines. So all we need to do is just angle the implant very slightly. As soon as you angle the implant slightly, the soft tissue retreats. Now, we see this orthodontically. Teeth that are crowded and facially positioned, we will often see the soft tissues much more receded than the neighboring teeth. You bring the tooth back into position, and the soft tissue follows. Everything becomes symmetrical and aligned once again. So that relationship between the curvature of the arch, the natural contour of the ridge and the soft tissues, and the position of the implant, crown and abutment complex in relation to that creates the situation in a facial position that creates recession. And if we go even further, if you combine an angular malposition. So it's a facial malposition called by an angular change, but you also have the implant completely bodily to the facial aspect, which we sometimes see. Then this is a severe recession, is a disaster, and it cannot be treated because the entire implant and prosthesis and crown are outside the normal confines of the dental arch. So why does this happen? Well, the reason for this is if you are inexperienced or if you're not alert to this when you place an immediate implant. The implant in a central incisor, lateral incisor site is placed in the apical palatal side of the socket. Now, that palatal bone is very dense. It's a dense cortical layer in the socket itself. And when the implant is placed, if you don't realize it, the implant can kick towards the buccal side. And if it's not picked up, then that implant is immediately in a facial malposition without your realizing it. And if you get the implant into a facial malposition, Jan Kozijn, I think in Belgium, in a very nice paper, calculated the risk. The odds ratio for recession, if you have an implant in a malposition, is 17.2. In other words, 16 times greater chance for recession. It basically means you're guaranteed to have recession. Put that implant into the wrong position facially, and you're almost guaranteed to have soft tissue recession. And I did a study in 2007. We published this with immediate implants. And here I documented the gap width between the shoulder of the implant and the internal part of the facial bone. And sites that had soft tissue recession were compared to sites with no recession. And the average distance between shoulder and facial bone at sites with recession was 1.1 millimeter, whereas sites with no recession on average had 2.3 millimeters. So the difference between successful aesthetic outcomes and recession was a 1 millimeter displacement of the shoulder of the implant. It doesn't seem like very much, but the soft tissues are so sensitive to having too much contour due to the facially positioned implant that it doesn't need much to create the recession. And how much is this? Well, maybe let's look at this geometrically. Let's say, for example, this diagram with the implant that's deflected by 1 millimeter. Let's say it's moved 1 millimeter to the facial. Let's say this implant is 12 millimeters in length, and we place it at 20 degrees angle to the vertical. So that's the position of the implant. And let's say now, after the placement of the implant is deflected at the incisal or the shoulder of the implant by 1 millimeter. So we can do the calculations. So that 1 millimeter deflection of a 12 millimeter implant is an angular deviation of not even 5 degrees. So it's such a small change at the apex creates a 1 millimeter deflection. And that 1 millimeter is enough to increase the risk of soft tissue recession. So this is something that we have to really, really guard against when we are placing immediate implants. And today, of course, we have the ability to plan our implant placements virtually with 3D software. We can then use guided surgery with surgical guides to ensure that the implant goes into the correct position and doesn't deviate once the implant is being placed. And this I strongly recommend to all my colleagues. And today, even though I've placed many immediate implants over the last 35 years of practicing implant dentistry, today I will use a surgical guide in guided surgery to ensure there is minimal risk of the implant deviating. Now, there's also facial malposition due to a mismatch between the implant socket and the ideal implant position. And there are a number of classifications of tooth position, alveolar bone position. This just happens to be one by Howie Gluckman in 2018. And you'll see different scenarios and relationships that we can pre-establish with our CBCT, so we can diagnose this right from the beginning. And these are the three situations where you run a very high risk of having an implant into a facial malposition because of the mismatch between the axis of the tooth and the socket and the axis of the alveolar process. Right? You could see that I put in implants into these three situations, and they all come through or facial of the incisal edge because of the need to engage apical bone. And in doing so, you bring the shoulder of the implant too far to the front. So these situations and these cases are actually not immediate implant cases. We should not be placing immediate implants, and we should be looking at other timing protocols to correctly place these implants. And by the way, if you think you can rely on an access, these angular correction, the ACS screws to correct your angle, yes, but the shoulder of the implant must still be far enough away from the facial bone to ensure you don't get recession. So you can't rectify a malposition that brings the implant too far to the facial with angle corrections. So recession over longer periods, as I then mentioned now, is due to ongoing resorption. So here is a case. Again, these are old cases now because these are the ones I documented when we were really looking at the complications. So you see this immediate implant, lateral incisor site, conventional loading. The crown implant was placed in 2003, the first follow-up 2004, then I have a follow-up 2007. So from 3 years after the initial placement and restoration, we have everything stable. Then we jump forward another 7 years and we can see the recession. The recession has slowly crept in, exposing the margin of the crown and the ceramic abutment. And 1 year later, it's really gone. So this is the danger we have with immediate implants. And in fact, in cases with aesthetics and implants, we might think we have a good outcome and it looks great for the first few years. But time will tell if the treatment that you provided is stable. And in this case, this immediate implant, it took 7 years before the recession on the midfacial mucosa started to show itself. And I have a number of cases like this. So this is another case. Upper left central incisor is the implant. It took 6 years before the recession started to appear on this immediately placed implant. And these were sites that did not receive grafting of any kind. This is back in the early 2000s. And if you look at these images, The image on the left is at the time the implant's placed. The image on the right is 6 years later after the crown has been taken out. Look at the tremendous amount of modeling of the bone that has taken place over a 6-year period because the facial bone was not reconstructed in a biomaterial that didn't resorb, like bios, for example, bovine bone mineral. This was allowed to heal naturally with the natural native bone. And this phenomenon has been documented quite nicely by Joseph Kahn in a paper he published in 2011, which was a follow-up paper that was published in 2003. So 2 time frames. What he did, he looked at, these are all immediate implant placements and immediate loading single teeth in the maxillary anterior zone. He looked at cases with thin and thick tissue phenotype and recorded the recession after 1 year. This is in blue. You can see the thin tissue biotype, the recession on average was almost 0.8 millimeters. The thick tissue was a little bit over 0.2 millimeters. Not much, but certainly in the thin phenotype, bordering on starting to become visible. He then recalled these patients on average 4 years later. The recession continued. It essentially doubled. So thin became 1.5 millimeters. You can definitely see 1.5 millimeters of recession. And thick soft tissue, the mean recession was almost 0.6, meaning that with the standard deviation and the extremes, there were cases of thick biotype which had a lot of recession. And so this demonstrates that the modeling of the bone can create ongoing changes if we don't take care to reconstruct that facial bone to be stable and not to undergo normal bone modeling over a period of time. And we know this because it has to do with the bundle bone on the facial bone. And this is where all the Araujo studies that looked at healing of extraction sockets in an animal model. This is undisturbed healing where most of the facial bone, or a lot of the facial bone, resolves because it's made of bundle bone. And even if we place an implant into the socket, the implant does not stop that facial bone from resorbing on the facial aspect. The implant acts as a passenger. It's a passive occupier of space. It has no impact at all on the natural remodeling of the bone that will happen post-extraction. So this is something important to remember. We also know a few details like this. The average resorption in the maxillary anterior region, this is from re-entry human studies, is 2 millimeters. That's a mean. So some cases can be much more than that, but on average, it's about 2 millimeters. We also know that most of this resorption takes place very, very quickly. Within the first 4 weeks, most of the recession or resorption of that facial socket bone is gone by then. And we also know that if you have thin bone, less than 1 millimeter in thickness, it's going to recede 2.5 times more than if the bone is thick. So immediately you can start to see the risk factors. Thin bone phenotype is a risk because you're going to get a higher proportion of sites receding. And remember, even if we put an implant into the extraction socket, that's not going to stop the facial bone from resorbing because the implant acts as a passenger. It's passive in the extraction socket. Then the pattern of resorption with that recession are these dehiscences. And so from our group, we've documented that most extraction sites and around implants will heal with what's called an inverted V-shaped dehiscence. And they can either be shallow or deep, or they can be wide. Now, the wide defects are the ones that are at great risk of soft tissue recession. Joseph Kahn referred to this as the UU or the double U defect with immediate implants. 100% of implants placed with immediate loading and grafting ended up with soft tissue recession simply because there was not enough bone support on either side for the graft, and I'll talk about that later, for the grafting material to be contained. Let me run you through now a preclinical study that we published in 2020, our group, and this was in a canine model, and it was basically looking at comparing 2 implant designs, a bone level parallel implant against a bone level tapered implant. And the primary outcome measure was the ISQ at the time of implant placement to see which could be placed with higher stability. Now, I show you this not for the main purpose of the study, but to show you the histology that came with it, which for me was quite an eye-opener. In this study, we used the second maxillary incisors in the dog model. So dogs have 6 maxillary incisors, and we place these implants into the second incisors, very similar to the lateral incisors of a human in terms of dimensions. And implants were placed randomly as either straight or tapered, and placed like we would be placing them in a human situation. Immediate flapless implant placement, leaving a 2 millimeter gap to the facial bone, grafting internally with bio-os collagen, and then using some type of collagen matrix. In this case, we use mucograft to form a seal, and all the implants healed with complete closure. And then looking at the ISQ, well, the results were significantly higher initial stability with the tapered design, the apically tapered design BLT implant compared to the BL implant. And so today I use tapered implants predominantly because they give us higher initial stability in extraction sockets, especially if you're thinking about doing immediate loading. As I said, that's interesting, it's fantastic, but for me, the most interesting part was the histology. So here's the histology of a tapered implant, looking at it in the sagittal plane. And what you see here is the computer assigning color to the hard tissue. Green refers to the bio-os particles. So this is our bovine bone mineral. Red is the newly forming woven bone, and yellow is the original native bone in the site. First thing you'll see is that that facial bone or the buccal bone has receded. Now the implants were placed with the shoulders of the implants at the level of the buccal bone crest. So in that 12-week healing period, an average of 1.5 millimeters of vertical resorption took place. Remember, the implant does not stop remodeling of the facial bone, resorption of the facial bone. It just occupies a space within the extraction socket. And then if we look at the coronal part, this coronal part of the implant is now completely reconstructed or regenerated in biomaterial. So bio-os is predominantly what is creating the facial bone wall. And the facial bone wall is considerably thinner at the crest than the original socket dimension, which was 2 millimeters. We had a 2 millimeter gap. All right, so this is what will happen in a human situation if you place an immediate implant. Exactly the same thing will happen. So let's look at this in higher power. So the immediate implant, even with a graft, does not prevent resorption of the ridge. And if we look in this critical zone here, we see actually a lot of bio-os particles, but not a lot of new bone forming around the bio-os particles. Bio-os is coated with bone in the more apical region. And this is where the graft is contained within the bone walls. Remember, I said that the facial bone resorbs rapidly. Within 4 weeks, it's gone. So the graft in this area is no longer contained within bone walls and therefore has lower regenerative potential because of that. So please bear this in mind as we go forward. Now let's look at peri-implant infection. We'll move on to this, which is a less recognized but a significant late complication. A patient that I treated again some years ago, upper left central incisor. The tooth was extracted flaplessly. The implant was placed. Grafting of the socket was done internally. There was no immediate loading. It was sealed off with a collagen sponge. And there's the implant after the initial healing. And then the case is restored. So this is the 2-year postoperative recall. And you can see from the arrow on the clinical image that there is a persistent fistula formation and discharge that I could not eradicate. Even with taking the crown off and debriding several times, could not get this to be eradicated. And if you look at the periapical radiograph, you think this implant has perfect bone support. So in the end, I had to raise a flap to see why this was happening. And this is the image of the flap raised. You will see that the implant that was placed just under the level of the facial bone crest. The new bone crest is now 2 millimeters or 1.5 millimeters, exposing the implant surface. You can see actually particles of bio are still embedded in the bone in the surrounding area, but there was a failure of the regeneration on the facial aspect. So this is infection, bacterial contamination of the implant surface. And of course, if this happened 3 or 4 years down the track and the patient is susceptible and you get peri-implant bone loss circumferentially, we say, oh, this is peri-implantitis. But the problem, of course, is the lack of regeneration of bone to begin with, a failure of the regeneration to start with. So here we have a case, immediate implant referred to me to the re-entry. This is 2 years previously. No regeneration of bone has occurred in that extraction socket. It's like the implant had just been placed. And why, and what happens? Why does this happen? So we've got schematically, and this, I beg your pardon, this should be bone regeneration, not degeneration. Bone regeneration in the marginal defect. If we have this resorb, then we have exposure of the implant threads and the rough surface of the implants. Now we have re-entry data from a number of classic studies. Today, we will rarely have any re-entry data on implants. But going back to 15 to 20 years, a lot of the studies did re-entries to establish the bone outcomes. Now, these are 4 papers. One of them is mine in 2007. This is the proportion of sites with complete bone fill. In other words, immediate implant place grafted with bovine bone mineral to the top of the implant shoulder. Re-entry, these are the proportion of cases that had complete fill. And these are the proportion of sites that had incomplete fill. Even in my study, I had more than 25% of the implants that I placed had a residual defect in the marginal area with exposure of the rough implant surface. So if you think about that, then you say, well, these implants are set up for peri-implant infection because the implant doesn't cover the bone. And indeed, these are 3 cases of immediate implant placement, and all have non-healing of the extraction sockets. So we have to try and understand why this happens and why this area, in this marginal area, has low potential for regeneration if the bone, facial bone resorbs. And can you imagine now, this is an implant that was placed by yourself, immediate implant, grafting of the socket, then immediate provisional. And then when it comes to doing the restoration, the crown comes in, comes off, comes in, comes off, adjusted, in, out, in, out. How does this affect this tissue, which is not really ossified yet? I sometimes wonder whether our restorative procedures actually do damage to this very delicate new immature bone tissue that's forming in this facial region. Maybe we have to take much more care in how we handle our prosthetic components when we do restorations to reduce the risk of losing some of this material. Okay, let's look at the source of osteogenic cells. Now, this is an extraction socket. Where are the bone progenitor cells coming from? They're going to come from the mesial wall, the distal wall, the palatal wall, and they're also going to come from the apical region and grow up. No bone will regenerate from the facial bone because the facial bone is predominantly cortical bone. There's no trabecular space. You need trabecular space bone marrow for angiogenesis, vascular formation, new blood vessels, and then into there come the bone cells, the osteoprogenitor cells. Now we take this extraction socket and we place an implant into it. We completely occupy 2/3 of the extraction socket. Where are the progenitor cells coming from? They can only come from the mesial and distal. The palatal wall cannot contribute because you blocked it off. The apical part cannot contribute because it's blocked off by the implant. So now you've reduced the potential for regeneration from 4 surfaces to 2 surfaces. And then we place a bone graft into the socket. And the bone cells, the bone forming, well, firstly, the blood vessels have to regenerate and bridge the gap on the facial, and then has to bring new bone all the way along to the midfacial surface, which is great. This is a thick bone phenotype. But what if you have a thin bone phenotype? what if the bone is as thin as this? And when you place the implant and you get that 4 weeks later, the loss, that inverted V-shaped dehiscence, suddenly your bios particles are no longer contained within bone and are vulnerable and at risk. So I think we have to think about the biology underpinning this sometimes when we look at doing immediate implants, particularly in our patients with thin tissue and thin bone phenotypes. So we'll make a statement here. To minimize the long-term risk of mucosal recession and infection, if we undertake treatment and we do grafting procedures for bone regeneration, we need to take steps to ensure that we completely reconstruct the facial bone wall. You have to completely reconstruct the facial bone wall. It's not enough to have 80% defect fill, 90% defect fill. We have to have 100% every time. And to do that, we need to use bone substitute materials like bios collagen, deproteinized bovine bone mineral, because these materials are osteoconductive and have low substitution rates. They can maintain volume at the site, and there's minimum turnover. So that's really what we've got to do. Remember, I go back to the biological or the therapeutic objectives. Thick bone, and the bone needs to be coronal to the implant abutment interface. Now, what we've learned in the last few years is the importance of the gap width to ensure predictability. And this was a study, I'd like to show you a study published by Bob Levine in 2022, together with Maurizio Araujo, a retrospective CBCT study looking at immediate implants and immediate loading, and all sites grafted with bios, all sites with intact facial bone. And the only real difference between the cases was the gap width on the facial side. So at the time of surgery, Levine measured the gap width to be either more than 2 millimeters or less than 2 millimeters, less than or equal to 2 millimeters. And if you looked at the gap width when it was less or 2 millimeters or less, sorry, let's look at the thick one first. If the facial gap was greater than 2 millimeters, then on CBCT, the bone thickness on average was 1.7 millimeters. And importantly, the crestal bone, 0.3 millimeters, was coronal to the implant abutment interface. Therapeutic objectives achieved. If, on the other hand, the facial gap was 2 millimeters or less, 2 millimeters or less, then the bone thickness on CBCT was only 0.5 millimeters, and the detectable bone on the facial of the implant was almost 5 millimeters from the implant shoulder. Wow. How important then is that facial gap? That facial gap size then becomes the critical clinical determinant on whether you're going to achieve successful regeneration of the facial bone. So we cannot rely on the facial marginal bone itself. If we place the implant and we have a gap that's wider than 2 millimeters, then what will happen is, because of a provisional matrix that's formed, and if we then anticipate some loss of the facial bone and some thinning of the facial bone, but we still retain enough to eventually reconstruct that facial bone. So you have to have a lot of thickness to begin with. You need to have a lot of gap space to begin with. And this is achieved by correctly positioning the implant towards the palatal side, also by selecting the size of the implant that matches the socket to ensure that you can keep that gap greater than 2 millimeters in dimension. So we cannot overstate that importance of the gap width. And a final determinant is how prominent the roots are in the alveolus. So if you look at this schematically on the left, this comes out of treatment guide number 13, ITI treatment guide. You can have roots in the sockets, and you can have thick bone surrounding them, and the interproximal bone width is the size of the ridge. Or you can have sites where the roots are very prominent and the interproximal bone width is narrower than the bone width at the central part of the tooth root. Because when these teeth are taken out, the risk of resorption and flattening is much, much greater than in sites of high risk. So when when we analyze our implants, we must also look at the axial views, which is the CBCT image you see on the right. That's the axial view to give you a sense of how quickly this bone is going to resorb. And when you plan your implant placement, the optimum positioning for your implant in an orofacial position to ensure the correct gap width. Okay, so let's move on to selection criteria. Aesthetic risk, of course, is an important determinant, and how risk averse you are in terms of your management of your patient. If you've got patients with a high lip line, high smile line, are you going to risk immediate implant placement? Do you look at some other alternative like early implant placement, for example? Do you look at socket grafting and a later implant placement? So, and then aesthetic risk in the eyes of the patient. How aesthetically concerned is your patient? And then with site assessment, look for thick soft tissue. If you can find cases of thick soft tissue, that's great because you have a much less chance of recession with thick soft tissue. And in this case, in this image here, you can see the soft tissues are actually more coronal to the adjacent central incisor on the tooth that's to be taken out. So this is a really good situation for an immediate implant. Now, it doesn't mean to say you can't treat thinner soft tissue, but as I will show you later, we have to do adjunctive procedures. We now have the benefit of CBCT scans, and what we need to look for are cases that have predominantly thick and intact facial bone. And if you don't have thick facial bone, it at least must be intact. Right? If you have damage to the facial bone, you're going to start to increase the risk of soft tissue recession because you cannot contain your grafting material if you do a flapless procedure. So the two images, as you can see, clinically, thick bone, thin bone. We now no longer need to open a flap to see this. We can determine this at the initial examination with CBCT assessment. Then we can plan the implant placement, and we can plan to have the horizontal gap width between the shoulder of the implant and the internal part of the facial socket wall. And we want that to be more than 2 millimeters. And that is then grafted with DBBM graft so that now recreates our new facial bone wall. And the graft is grafted coronal to the implant abutment interface, meaning the implant has to be placed slightly deeper in the socket under the level of the bone crest to achieve that coronal regeneration of bone above the interface. We need sufficient apical bone to anchor the implant for primary stability. And then we need to be aware of the relationship, as I mentioned previously, of the tooth and tooth socket in relation to the alveolar process and the planned implant position. Right? And in the ITI Treatment Guide 14, they go through this in quite a lot of detail and talk about the safe zone, caution zone, and danger zones in terms of how the teeth are related to the alveolar process. So when bone and soft tissue conditions are not ideal, you can still do immediate implants, but you have to be prepared to undertake adjunctive hard and soft tissue augmentation procedures, such as opening a flap so that you can graft not only internally, but also externally to the alveolar bone. You can also then add soft tissue with a connective tissue graft. So all of a sudden, this procedure becomes much more complex because additional procedures are being performed. Experienced clinicians, of course, are able to manage this, but for those with less experience, then it might be better to look at other treatment options rather than an immediate selection. So this case might not be the right case to select for you to perform, because we must always look at our own ability with our clinical procedures. And if you can place an implant that has high primary stability, you can then consider an immediate restoration or an immediate loading protocol, which has high patient-centered benefits if you can do this. So here I'd like to refer you to and I've referred to this already, the 14th volume of the ITI Treatment Guide, edited by France Lambert and Adam Hamilton, where they looked at immediate implant placement and loading for single or multiple teeth requiring replacement. And what they've come up with is a really very nice risk assessment table of low risk, medium risk, and high risk. And in terms of the domains as a preoperative assessment, site related, And they also have an intraoperative assessment that's during the procedure. Did you achieve stability? Was the extraction done without causing damage to the facial bone and so on? Yep. So it's not just preoperative, but it also is an intraoperative assessment as part of the planning process. And the ITI has also produced this, which looks quite complicated, but it's really just an algorithm, a decision tree that will assist you or assist us in making a decision when to place the implant immediately, when to do early placement, when to graft the socket and do a late placement, and what are the relative risks with this. So I would encourage you to go to the ITI website and look for this decision tree, because I think it can be quite valuable in terms of working out the strategies and the decisions for which timing of implant placement and which loading protocol would be most appropriate for the case that's presented to you. So let's finish off with some cases. This is case one, and you can see immediately we have a patient with very, very high aesthetic risk. High lip line, extremely thin soft tissue phenotype, triangular teeth, relatively long papillae, thin tissue phenotype, and probably thin facial bone as well. You can see from the radiograph of the left central incisor crown, she's fractured the root in the apical third. Although there's no outward sign of infection, the tooth is now unstable and we need to consider its replacement. And an implant would be the option of choice. So immediate implant placement. I wonder how many of you would say yes to that. Would others say maybe we want to try a lower risk solution? Okay, so let's look at the CBCT. So when you look at the CBCT, you can see that this has an apical constriction, thin bone phenotype, although the bone walls are intact. There's an apical constriction, and there is a good chance the implant may not be able to be placed in the correct position because to engage the bone, the implant would need to be a little bit more palatally placed. And if the implant is palatally placed, then the axis of the implant may come too far to the facial. And when we look at the occlusal view and we look at the axial view of the CBCT, you can see that the roots are quite prominent in the line of the arch. So let's look at this assessment table. And I've gone through this and filled this in, and I'll just hit one button and all of them will come up. So you can immediately see there are a lot of red flags, a lot of yellow and a lot of red flags. So for me, this case is much too high risk to do an immediate implant. Too many things to go wrong, and I can't even afford to get 1 millimeter of recession. Even 1 millimeter of recession would be enough to completely ruin the case because the patient has such a high lip line and smile line. So in this case, we opted for a conservative approach. I grafted the socket, waited 3 months, then re-entered, placed the implant. And you can see here the apical fenestration that has to be created intentionally to get the implant in the correct axis. And then a further augmentation procedure is performed. So a second round of grafting is performed. This to repair the fenestration defect and also now for additional contour augmentation. This is the healing after 3 months, connection of the healing abutment. To cut a long story short, we have the 6-year outcome for this patient. Good aesthetics, although you can see if you look carefully, the shape of the tooth, the crown of the implant is a little broader than the natural shape of the right central incisor. But I think overall, a good aesthetic outcome in a high risk individual. Now let's contrast this then to this case that was referred to me early last year. Upper right central incisor where the crown has separated from the root, not enough retention for a new crown, and some internal caries has happened. So the whole thing has been rendered a hopeless prognosis. But you can see here the patient has a relatively low lip line, does show the tips of the papilla, relatively thick soft tissue phenotype, no apical area, periapical area can be seen on the radiograph. So you think, and the soft tissue level is more coronal on the right central incisor, on the left central incisor. So in many situations, it looks to be a very high possibility of doing an immediate implant placement. Okay, so Here are the CBCTs taken to establish whether an implant can be placed. And you can see the several views, including the axial views. And remember, always look at the axial views, which is this view here, because this gives you so much information about the thickness of the bone, the prominence of the root in the arch, the propensity for resorption to take place, and so on. And just in the CBCT software, I put an implant into position just to give me a rough idea. Yep, it looks quite feasible to get this implant into a good position, to have good stability, to have the implant emerge just behind the incisal edge in the cingulum area. So this, in fact, would be a good case to consider an immediate restoration or an immediate loading protocol. So we take the scan then to our planning software. In this case, it's Code Diagnostics, and we can place the implant, place the abutment, and make all the decisions about the implant positioning, the gap width on the facial side, the distance between the abutment height and the soft tissues. Everything can be done and pre-planned. And from this initial planning, it confirmed that an implant can be placed in the correct axial position whilst respecting all the parameters that I discussed in terms of implant positioning. Implant shoulder is apical to the facial crest. The facial gap is greater than 2. Apical bone for primary stability. It ticks all the boxes. And here is the risk assessment. And the risk assessment is pretty much all green. The only yellow is that the facial bone plate is less than 1 millimeter in thickness, which means that there's going to be a greater propensity for that facial bone to resorb. But if we place the implant in the correct position and have a greater than 2 millimeter gap, then we should be able to maintain that facial bone wall after healing has taken place and the natural remodeling of the bone occurs. So in this case, we plan for an immediate implant placement and an immediate loading. This is the design of the surgical guide. And you can see it has incorporated one bone anchor pin in the midline. And this is to stop the surgical guide from rotating. And the reason we don't want any rotation in the guide as you're using it is because we have prefabricated a provisional crown. So we want to prefabricate the provisional crown. It's ready to go. It's pre-sterilized. And at the time of surgery, if all goes well, it can all fit together. Right? So that was the plan. So you can see the extraction of the tooth. Then guided surgery is occurring, and the rigid fixation of the guide to ensure no movement of the guide whatsoever. The implant is then placed through the guide, because if you freehand place the implant, it can deflect to the facial side. So we want to use the guide to help with the positioning of the implant. Obviously, we need to choose the design of the implant that's going to provide high stability. And then once that's done, graft the socket and then connect the provisional crown. And here, to compensate for some soft tissue thinning, which might take place with the resorption of the bone, I've used here, this is a piece of Geisslich fiber guide. It's a soft tissue substitute. And this is being incorporated into that transition zone or that subcritical zone between the crest of the bone and the soft tissue margin. So this is being tucked underneath, and then the crown is seated into position and it's held in position. All right. So you can see here the provisional crown has been constructed with minimal adjustment and the control radiograph that was taken. This implant, of course, is taken out of functional occlusion, the crown. The patient is advised very carefully to be very careful not to masticate directly on the crown and to be very careful. And then we allow healing to progress. So here is after 3 months, very nice soft tissue profile, soft tissue conditioning. And if you look at the occlusal view, maintenance of a nice soft tissue contour with minimal resorption of the ridge. So there's hard tissue reconstruction. There's also soft tissue augmentation done with the fiber guide. And this is now the definitive prosthesis. This is 1 year after insertion of the final prosthesis. So case selection allowed the treatment to be performed in a stepwise way with minimal risk of complications. So with that, ladies and gentlemen, I would like to make a few conclusions. Firstly, to recognize that immediate implant placement is a well-documented procedure. At the 2023 Consensus Conference of the ITI that was held recently, and this was a major topic, we recognize high survival rates of implants and high success rates of immediate implants and immediate loading when all the correct protocols are observed and when the cases are selected carefully. So you can expect good long-term survival and success rates provided the strict inclusion and exclusion criteria are applied when selecting cases. And I would encourage you to use the ITI's risk assessment guide that was published in the treatment guide 14 for immediate implants. And if you do treat cases of thin bone and soft tissue phenotype, or there is some damage to the facial bone, then you need to undertake adjunctive procedures like opening a flap, like grafting externally to the facial bone, like using additional soft tissue grafting. And remember, of course, that increases the complexity of the treatment and risk. Or you can revert to an early implant placement protocol where you take the tooth out, allow everything to heal, the soft tissues will naturally thicken. Then you can deal with an implant placement and a grafting GBR contour augmentation in the technique described by Danny Boozer, and also get a high predictable result. Okay, so I think that's a very important consideration, that although we might be thinking about an immediate implant for a particular case, if the conditions are not right, sometimes intraoperatively as well, then we have to have the fallback option of going to an early implant placement protocol. And so with that, ladies and gentlemen, I thank you very much for your attention, and very pleased to answer any questions that you might have.